Before viewing video lessons, it is important to read the textbook using the learning guide as your turn-by-turn directions. Then use the learning guide to take organized notes in your own words with examples and pictures.
All right, so most of what we're going to talk about today is focused in Chapter 5. We're going to pull a little bit out of that part of Chapter 7. But before we talk about these diagnoses, a couple of reminders. This is from way back at the beginning of the semester when we were defining what is abnormal, what is crazy, what's a psychological disorder. You guys remember that? 3 factors: distressing, dysfunctional, atypical, right? Every diagnosis we're going to talk about in this class is going to have those 3, with just like 2 exceptions, and I'll tell you the exceptions when we get to them, and I'll highlight them great big. So here's the thing about a lot of disorders. Your psychology, your thoughts, actions, emotions exist on a continuum that's constantly fluctuating, right? So sometimes you will read about a disorder and you'll identify with it because you'll be like, sometimes I'm like that, right? Sometimes I fluctuate in that way. Sometimes my mother does that, or my boss does that. You know, you'll see these behaviors and these thoughts and emotions in others as well. Doesn't necessarily mean it's a disorder. So you might look at some of these and say like, well, lots of people do that. Lots of people may sometimes do that, but do they do it in a way that is extremely dysfunctional, distressing, and atypical? So kind of try to keep that in your head as we're going through and we're talking, okay? This is a point I just brought up a couple minutes ago. The other difficulty with these chapters is they're grouped together based on similar symptoms, and we believe similar causes. So we think that the dissociative disorders, for example, have similar roots that cause those symptoms in people. And as a result, similar treatments are going to be used. But each one has something unique about it that makes it stand out, and those unique features are what you need to make sure you're paying attention to. So on the test, you can tell the difference between the diagnoses. What do you need to know for each disorder? What should you be prepping and studying for this exam and all the exams going forward? The most common type of question you're going to see are going to be diagnostic criteria related questions. And most of those questions are going to be application or scenario based. Mary is experiencing X, Y, and Z for this amount of time. What's the most likely diagnosis? That's the type of questions you should be prepping for. There will be some about prevalence, which will be statistics. Make sure you're writing some of those things in your notes since you get to use your notes, right? Etiology and prevention. So there'll be some questions about that, and there'll also be some questions about treatment. So this is on the learning guide. It's on the bottom of the learning guide for these disorder chapters, and so this shouldn't be something new that you haven't seen before if you're using those learning guides, but I like to highlight it in class, okay? So let's pick up where we left off last time. So we were in the middle of this set of learning objectives last time. We had started with the first one about the DSM-5 and this relationship between physical and mental. We hadn't quite finished that one yet. So we're going to finish that, and then we're going to get into the somatic symptom and related disorders. So what makes this even more complicated is you can have a mental problem and a physical problem at the same time, and they're going to cause and complicate and make things worse. And this is true for having both a mental condition and a physical condition at the same time. You can also have more than one mental condition at the same time. We call that comorbidity. Before class started, we were having a little chat about people with anxiety disorders being at increased risk to also have depression. and to also have substance use disorders. So you can kind of have three things going on at the same time, and each one's going to kind of complicate and make the other worse. And so the same is true for physical problems. In addition to all of that, some of the mental disorders, so these aren't classified as physical disorders, they're classified as mental disorders in the DSM-5, have known clear organic components. There's clearly a biological trigger, complicated by psychological, social, environmental factors, right? But they're in this chapter because the primary presentation is thoughts, emotions, behaviors that are disrupted. So for example, intellectual disability, we used to call that mental retardation. Almost every case has a biological root and a genetic or chromosomal abnormality or an early assault on the brain during the prenatal time period, like exposure to a toxin, okay? Autism has clear genetic roots. I just read a fascinating study this morning about ADHD, and we actually have genetic copy errors that we've identified as a signature for ADHD, so I need to add that to this list. Some of the somatic disorders that we're going to be talking about today. Dementias all, by definition, have a medical physical cause. Sexual disorders oftentimes have a physical component, and sleep-wake disorders have a physical component as well. So it's going to be complicated. You know why? People are complicated. So it's sometimes trying to figure out where's the line between the mental and physical is difficult, which is why we should stop doing it. Okay? So we're going to shift our focus now, and we're going to talk about those somatic disorders. Before I go through the diagnoses, I got to teach you a little Latin. Medicine loves Latin. So soma, the root word in somatic, means body. So if somatic doesn't work for you, you can reframe that in your head as body symptom and related disorders. So somatic symptoms are symptoms associated with the body. It can either be a preoccupation with the physical health or a preoccupation with the functioning or appearance of the body, like something about my body is weird. Because it has a body symptom, it suggests that this could be a medical condition, right? So if I go to the doctor and I say, "Doc, it hurts here," they're not going to start with examining my head, right? They're going to start by exploring all the possible biological, physical reasons why I have a bellyache. So most somatic symptom and related disorder diagnoses aren't made until after there's been significant medical evaluation and assessment to determine what's going on. The other thing you have to think of is that this is going to be associated with significant distress and impairment. All of you have had a somatic symptom before. You're going to get up and you're going to give a speech in class in front of all these people, wearing a mask, for God's sake, in the middle of a pandemic. That may make you feel better or worse. I don't know, the mask. It's like, you can't see my face, you can't see I'm turning red. But if you feel that kind of butterfly feeling and you're like, oh, Professor Buck, I'm not feeling great today, and it's only your nerves that are causing that, that's a somatic symptom. You've all felt it before. What makes somebody with one of these diagnoses different is that significant distress and impairment. It's not just one little moment, it's a continuous dysfunctional aspect, okay? Now, here's the other kicker with these. a physical cause. But the physical cause doesn't fully explain the symptoms that you're experiencing. So you may have a physical explanation for why you get a little bit of a bellyache, but your bellyache is way worse and you can't function, and it's like, you should be functional. No, I can't function, but you should be biologically, physically, medically. You know, it's uncomfortable that you should be able to function. It's way worse because of psychological factors. So I like to talk about those medically kind of related diagnoses and these diagnoses together because the line between them is very fuzzy, right? I think in the future, you're going to see these kind of melded together a little bit and hopefully more clearly delineated or combined in a way that makes more meaningful sense. So what happens for these disorders is that they're either caused completely by psychosocial conflict or stress, or there's a medical issue that's made significantly worse. So here are the diagnoses that are listed in the DSM-5. As I mentioned on Tuesday, a lot of times I'm going to show you the old version and the new version side by side. Sometimes it's because the old words are still used and they may make more sense to you. So for example, illness anxiety disorder, that's a new term in the DSM-5. We've never had that term before. Most of the people that meet that criteria today used to have a diagnosis that we've retired called hypochondriasis. So everybody's heard of hypochondriacs before, right? That's not a term we use anymore. It's not clinically meaningful anymore. So most of those people would now fall under this category. Some would be in the somatic symptom disorder. So I want to talk through all of these diagnoses and something that's not actually a diagnosis, which is malingering. The first disorder I want to talk about is an actual disorder. It's called factitious, or in your mind, because that word sounds kind of funny, faking disorder. But here's the thing about factitious disorder. We need to contrast that with something that we call malingering. So if somebody malingers, they're faking being ill, they don't have any real symptoms, and they're doing it for some kind of real, tangible, conceivable personal gain. Like when you call your boss and say, I'm so sick today, I can't come in. All right, stay home. And then you go fishing, right? You're faking it just to get something. Money and time off are the two reasons people are most likely to fake, okay? Factitious disorder is more complicated, okay? For people who have factitious disorder, there's no clear thing they're getting out of it in like a tangible sense, except attention and sympathy, right? They can go so far as to actually do things harmful to themselves to create a symptom that would give them attention and sympathy. So if you have little kids, you know what syrup of ipecac is? Anybody know what that is? Okay. You can use it to induce vomiting. So if the kid, drinks some poison, called poison control, sometimes they say don't make them throw up because that actually causes more damage. But other times they say make them throw up as quickly as possible. So you can give them this stuff and it makes them throw up. So somebody might take that, actually make themselves sick, right? They create that symptom, and then they, present for attention and treatment and medical care. You can have it in yourself, where you're faking in yourself. You can also fake it in somebody else. And the most likely person that you would fake it in would be a child, because usually you have to have some kind of power and control over that person's life in a way that maybe I wouldn't have with somebody who is more of an equal, like my spouse, right? That's factitious and malingering. Malingering is always a consideration. It's not just in mental health issues, it's also in physical health issues. My back hurts, I can't work anymore, I need disability. You get your disability check, and then you're out playing golf, right? So it's not just something exclusive to mental health. Okay. Somatic symptom disorder. In the old DSM, we had a bunch of different diagnoses that now kind of fall underneath this label. So 2 criteria. You have to have at least one somatic symptom that has to be distressing and interfere with functioning. Now, the somatic symptom is a real symptom. I'm not faking the belly pain. It really hurts. I am subjectively really experiencing this symptom. But medical professionals say there's no medical explanation, or the medical explanation doesn't account for the amount of pain that you're in, right? Common somatic symptoms are weakness, just a general feeling of blah, ill, fatigue kind of thing, and pain. So I have this symptom. The doctor says, I can't explain it. And it's severe enough that it's interfering with my functioning. It's upsetting to me. People with this diagnosis end up spending a lot of time and energy devoted to their symptom. They will start detailed diaries tracking their symptom, trying to understand it and explain it. In the world of the internet, they'll get online and start Googling their symptoms and trying to figure out what's wrong with them. And if they go to WebMD, what's the first thing that's going to pop up? Cancer. Whatever symptom you put into WebMD, cancer always pops up, right? Always. It's always there. And people start to get really anxious about this. Like, what is going on? I don't understand it. You can't fix it. There's nothing that's happening that's making this go away. It's upsetting. And for many people, this sort of becomes their whole existence. This diagnosis depends on medical science being able to fully explain everything, can they? So sometimes people feel very frustrated because it's physically real to them, and this diagnosis tells them it's in your head. And there have been times in history when we didn't fully understand what was going on. And later on, we were like, oh, we figured out what causes that. It's really physical, right? And so people don't feel comfortable with this diagnosis when they get it, because they're having this very real physical feeling. There's got to be a physical explanation. And so it's possible that some people may even be misdiagnosed, right? They have a real physical condition. We just don't have the medical science to detect it right now. All right. I'm going to point this out just as a kind of study tip or tool. In the textbook, most diagnoses are going to have these little boxes that say DSM-5 up in the corner. And that's going to be a summary of most of the criteria straight from the DSM-5. I'm not going to focus on those in class. I'm not going to go through each one of those in class. If you were taking this class at a graduate level, you probably wouldn't even have a textbook. We would just give you the DSM-5, and that's all we would study and focus on, right? I point these out because if you're reading in the narrative, and you're like, I can't tell the difference between somatic symptom and illness anxiety, sometimes you can go to these boxes and you can kind of find the differences and highlight those for yourself, okay? But let's talk about illness anxiety. So as I just said, there's no real physical symptom. There's just the worry that I might have something lurking in my body that's undiagnosed and asymptomatic. I think that I could have cancer. Well, why do you think that? Because sometimes cancers are hidden, right? Sometimes they don't have symptoms until it's too late, and then you're dead. My uncle had prostate cancer, and they couldn't find out that he had it until he was like, past the point of no return. Maybe I have that. Could I have that? I could have that. You see how that could happen? So the people most at risk for this are people who have had family members with significant health problems, right? Especially if it's a significant health problem that started out asymptomatic or with very mild symptoms but became serious, which cancer does that. You can have cancer in your body for years and not really know it, right? And so people have just this preoccupation that they could become sick. They fear illness, and they're extraordinarily anxious about it, but there's nothing wrong. These people do even more bodily monitoring than the first group. So they'll start tracking all kinds of things about their body and focusing on things, and they'll be like, oh my gosh, my stomach is starting to feel a little bit rumbly. Do you think that's Crohn's disease? What'd you have for lunch? A chili dog. Yeah, it's Crohn's disease. Lay off the chili, right? And so sometimes they may even have a real kind of temporary symptom, but it's explained by eating a chili dog, right?
For doctors.
I feel so tired. I have no energy. How have you been sleeping? Oh, I don't.
Or the way like
Take it back. So their whole life becomes about not figuring out what's wrong with them because they don't have something just yet, but avoiding it. And so they may become a little bit like obsessive with health supplements and exercise and, certain things like, oh, I don't do dairy. No, I can't do dairy. Like, well, are you lactose intolerant? No, but I read that it might complicate things if you had Crohn's disease, so I just don't do dairy. That their life becomes about avoiding getting some kind of illness. So conversion disorder is the oldest diagnosis. Freud was the first person to diagnose somebody with conversion disorder, okay? We actually have a new name for it, and I think in the future this will be the only name. Functional neurological symptom disorder. This is similar to the somatic symptom disorder we just talked about, in that there's a physical symptom. But it's more precise in that the physical symptom suggests a neurological illness or injury. So one of the most common neurological illnesses or injuries is a stroke. Stroke, you have a blood vessel clot in the brain and a piece of the brain dies. After the stroke, people have a characteristic set of symptoms. So if I have a stroke over here on the left side of my brain, then one of the things we can see is weakness or paralysis on the right side of the body, okay? So somebody shows up and they've got this paralysis or weakness on the right side of their body. And we can measure it. You may have had measurements like this before if you've had like an arm injury or neurological injury where they test like hand strength and they'll have you squeeze on different things to test hand strength, right? So I can test it and there is real weakness. It's a real symptom. But there's no stroke. The neurologist, who's most likely to diagnose this, is going to go through and check. Your nervous system is fine. There's no biological, physical, organic explanation for the symptom. So the common things we see are things like paralysis or weakness, blindness, and difficulty speaking. I have a latex sensitivity, and part of that also involves being sensitive to things like bananas and pineapples and avocado. There's some similar compounds. So sometimes if I eat pineapple, especially raw pineapple, my tongue will kind of swell up a little bit, and it'll be harder to talk because my tongue is like bigger than it's supposed to be, right? And my speech sounds a little bit slurred if I do that. That would be kind of like that difficulty speaking, right? So it seems like something physical is going on. Like, oh, did you have an allergic reaction, right? No. But here's where this disorder is different from somatic symptom. In somatic symptom, I am worried about this symptom. I'm concerned about this. What is wrong with me? Many people who have conversion disorder are like, they're not concerned. I had a patient once who was a nurse who had this diagnosis. Hers looked like it was a stroke. So she came into work one day, and when she walked, you could kind of see that one leg was dragging a little bit, and she had weakness in that arm. So if she had to turn a patient or do something, that she was struggling with that. And she even had a little bit of weakness on that one side of her face. She wasn't that concerned about it. Her boss was like, you go get checked out, right? So boss forced her to see the neurologist. Neurologist saw her, checked her out, she was fine. Came to me. The symptoms all started around the same time. Significant marital distress increased. And then she started going through the process of a divorce. Now, she could acknowledge that she was upset by the divorce, that the whole relationship dissolving was terrible and horrible and stressful, but wasn't too worried about this. See how this is different from somatic symptom. All right. So the last diagnosis in here is one that I've already mentioned, but I just want to re-mention it again. This is in this chapter, and that's the diagnosis where you have a psychological factor affecting a medical condition. So I mention this again because the somatic symptom disorder could have some physical cause, but the symptom is bigger than what the physical cause would explain, right? How is that contrast with this? It's very fuzzy, right? Let me tell you how to distinguish it. If the person is having this psychological factor that's making their asthma worse, but their asthma is fully explained and they're not having all this anxiety and worry and focus on their life of what's wrong with me and you can't help me, then we'd give them this diagnosis and say the stress is making your anxiety worse. If they were coming in and had maybe just a barely touch case of asthma, I reported it constantly, I can't breathe, I'm suffocating all the time, and you can't explain it, that would be somatic symptom disorder. It's a fuzzy line. I wish it was clearer and brighter, but right now that's where we're at. Okay? So I got a stats slide, gotta love stats. So I think it's important to put these diagnoses in context, like how common are they? So the most common diagnosed is somatic symptom. Illness anxiety is much less. So somatic symptom is 5 to 7%, illness anxiety 1 to 5. Conversion disorder is rare. The fact that I had a patient once that had that when it wasn't my practice's focus is kind of remarkable. The only place we can really focus is patients that go to a neurologist, right? Because they're the ones that are going to have to initially rule out neurological factors. About 5% of neurology patients. Now, the last one It may actually be the most common, the psychological factors affecting other medical conditions. But right now it's not for two reasons. One, it's brand new to the DSM-5. And two, it's not noted in the chart very often. So as I mentioned last time, the doctor may say, yeah, stress is making your anxiety worse, but they don't chart it. They don't put it in there, right? And so it may not make the stats because of that. Most of these tend to be lifelong things. They are chronic conditions. All right, so what causes these? Get ready to hear the horse I'm going to beat to death all semester long. It's complicated. It's going to be a complicated interaction of biological, psychological, and social environmental factors for every individual. There's no single causative route. When we talk about causes, in this case, we're talking about things that are associated with the diagnosis. These are correlational. We see that people who get these tend to be a little bit more neurotic. So if you remember your personality Big Five scale, neuroticism is this tendency to express and feel negative emotional states, anxiety being a big one. People tend to have some cognitive perceptual distortions that are similar to obsessive compulsive disorder. So the way they kind of think about the world and perceive the world and assess danger and risk is a little bit different from other people, but looks more like an OCD. If you didn't pick up on this, stress is a very common trigger. Many people who develop these diagnoses, they're set off by a significant life stressor. Many of them also have a chronic history of trauma or abuse that goes back into their previous life. Now, there's two other sort of factors that play into this. One is called primary gain. So with the primary gain here, I feel anxious. Oh my God, that's a crazy thing. I'm not a crazy person. I can't be crazy. I can't think about psychological issues. Divorce yourself from your emotions and feelings. Bury them. Oh, my stomach hurts. I can't go to work today because my stomach hurts. It's not that I'm anxious about the big presentation I have to do. I really have a belly ache, and I really do. I created the belly ache because I didn't deal with the emotions. It's more acceptable for me to have physical symptoms than emotional symptoms. I'm more comfortable talking about my physical symptoms. I'm more comfortable seeking help for a physical symptom. And so I'm getting something out of it that I just can't because I'm so disconnected from my emotions and my thoughts. Another big factor is reinforcement. Attention. Whew. I am feeling very overwhelmed by life right now. Yeah? So is everybody. Suck it up. Oh, I think I'm coming down with the flu. I'm just, oh, you poor baby. Let me take care of you. Do you see the difference in response? I always think about how you were treated when you were a kid and you stayed home sick. And if your mom was really nice, she may have set you up for this, right? Because you're like, oh, I wish I could just stay at home in my PJs and mom's going to bring me a grilled cheese sandwich with the crust cut off and it's cut into cool shapes and a bowl of soup and I'm going to get to watch TV and I can just, who would like to be a 6-7-year-old today? I mean, oh my God, that sounds like the life, right? So sometimes that's what happens too. And then as I previously mentioned, family history of medical illness puts you at increased risk, particularly for illness, anxiety disorder, that kind of worrying, like this runs in my family, I've seen this happen to other people, but it can play a role in the others as well. So the last section of this chapter is what can we do about these? Both the somatic disorders and the physical disorders that are worsened by psychosocial factors. Some of the biggest things we do is help people with stress. So we have comprehensive stress, and this is also something that's big in pain management programs. So when I worked in a pain management clinic, this is all the stuff that I did. Biofeedback is great for both pain and stress. A lot of us are not in touch with our bodies, our emotions. We like to just put that over there. Biofeedback helps you connect. We make a physiological thing visible. So with biofeedback, I would bring people in, I would put different sensors on their body that could sense stress. So I would do lots of different muscle tension sensors. So I might put some on the head if they like to clench up in their head, right? I might put them on their jaw if they tend to clench their jaw when they're stressed. This was my favorite place because this is where a lot of us carry our stress all day long, right? So I'd find their stress muscle. Respiration changes, heart rate changes, galvanic skin response. The level of sweat on the surface of your skin is associated with stress. Hook them up to these sensors, find the one that works for them or combination, and then we can show them on the computer screen. Here's your muscle tension. You're feeling stressed right now, huh? Then let's find different ways to manage that. Let's try this. Let's try that. So we can experiment in the therapy room with different ways to try to get that line to go down. They don't all work equally for all people. So we may try meditation. Well, that didn't work. We may try progressive muscle relaxation. That didn't work. We keep trying until we find the one that's most effective, and then they practice that one and they get good at it. And they get that line to go lower. By making it visible, they can see it. Different relaxation techniques. My favorite is the progressive muscle relaxation. That's the one that works the best for me. If I'm feeling really tense, I'll do a mini one because I also carry stress here. And so I can just tense it up. And you just do that a couple of times and you feel better, right? Cognitive therapy would focus on the thoughts that are driving the stress, right? So what thoughts do you have before you start to feel this physical symptom? What thoughts are you having that's making you stressed, that's making you sick? I can't get anything done. If I can't get anything done, then I'm not going to be able to study. If I don't study, then I can't pass this test. If I don't pass this test, do you see how the thoughts, right? So cognitive behavioral therapy is going to look at that and then help you interrupt those thoughts and come up with thoughts that are more functional for you. Sometimes cognitive therapy is going to target the symptom monitoring. In some people, the symptom monitoring is actually making them worse. That behavior is making them more sick. And so we may use the cognitive behavioral therapy to interrupt that. Sometimes it's coping strategies. Why are you so overwhelmed at work? Well, every time somebody says, hey, can you do this? I say yes. Stop it. Be assertive. Take control of your time. And then most of the time for people with these diagnoses, it's not just going to be one technique. We're going to have a whole collection or host of techniques. But this is what happens when you meditate. So remember that stress response we talked about? How the amygdala yells and the hypothalamus hears it and activates these two different pathways. When you relax, not only does it turn that system off, but it turns some things on that make you feel better. And if you are physically ill or injured, it enhances the immune system and your ability to overcome and deal with whatever physical issue you might also be having at the same time. So psychosocially, we can also do some things that are beneficial by doing some education and also support groups. So cancer and pain in particular tend to respond well to educational psychosocial support groups. And so you can think about like a breast cancer support group that would talk about educationally healthy habits, but then also provide emotional support to one another. Some other things that behavioral medicine specialists and people in treatment for one of these related conditions would do is just recommend being healthy overall. But in the case of illness, anxiety, and somatic symptom, not overdoing it. And so talking about just generally good health habits. And this final slide is going to come up over and over and over and over and over and over and over again, which is good neurological health habits. You're going to see this almost every day of class. I gave it to you in the handouts because it applies to every disorder. These habits are good for your physical health, but they're also really good for your brain, and they reduce your risk of developing a psychopathology. Final thing on treatment is particularly for somatic symptom disorders. If the patient has a history of trauma, therapy related to that trauma is necessary. So if you have somebody with an extensive history of abuse as a child, addressing that abuse in a therapeutic climate is going to be necessary for them to move on and deal with what they're feeling in the present. Because the past is what's fueling that. The most common form of treatment, the most effective form of treatment, is cognitive behavioral therapy. Another thing that is unique to the somatic symptom disorders is to assign a gatekeeper physician. Sometimes people with these diagnoses can do what we call doctor shopping. So they can kind of shop around to different doctors and, oh, you didn't tell me what I want to hear, so I'm going to go see you. And, oh, you know, it actually puts them at risk for more physical harm because then they're more likely to have invasive diagnostic procedures that can also kill you. You know, any surgery could potentially kill you, right? So we're going to do exploratory surgery in your belly. They could cause damage. I could be injured by that. So having a gatekeeper kind of bring all the specialists together is helpful. And then finally, antidepressants are helpful for some people. Antidepressants don't just deal with depression, but they can help people who are having somatic symptoms related to anxiety and being upset. And so for some people, an antidepressant can be effective.